extremely similar way, the adult guidelines. So some of this I'll be able to go through a bit rapidly because you just heard the exact same thing in the morning. And I'm going to highlight things that are different between adults and kids. So there are, as you know, many, many differences between adults and children. So this is going to highlight the brand new adult 2010 guidelines that came out in April 2010. Okay? All right. Do I have a thumbs up? All right. All right. So now we're going to be talking about the adult ARV guidelines that came out in April 2010. And we're going to go through, just as we did with the pediatric guidelines, taking who's eligible for ARVs, how do you diagnose somebody with HIV, what some of the symptoms you can have, what are some of the clinical manifestations, what are the actual criteria that we use, how do you assess whether somebody's ready, what are the medicines we use, and then what are some of the special situations that we need to worry about. And that's what we're going to do in this lecture. And just as an overview, we're going to review the goals of the treatment of ARVs for anyone in general. We're going to talk about the use of ARV medicines and what it is, what are ARVs. We're going to talk about which ARVs are available currently in South Africa, which is now expanding. We have 2 new drugs that are available to us now that a year ago, 6 months ago, weren't even available to us in the public sector in South Africa. So as you can see, it's always growing. And so with some of these new things, what are some of the side effects? What are some of the precautions? What are some of the things we need to worry about and be looking for in patients on these medicines? And of course, the new updated 2010 national adult guidelines that came out in April this year, and some of the challenges and limitations to the current ARV therapy. So what is the goal of HIV therapy, of HAART, of ART? Well, it's no different than anything else. It's no different than the treatment of diabetes. It's no different than the treatment of high blood pressure. It's no different than the treatment of high cholesterol. All of those things are the same. We want to improve the health of a patient and prolong their life. We do that with any chronic illness. Diabetes, high blood pressure, high cholesterol, heart disease. Any of these things is exactly the same. The same is true with treating HIV. We want to improve a patient's health and prolong their life. And that's exactly what ARVs do. Once somebody's on ARVs, we monitor their CD4 and their viral load. Just as in a person with diabetes, you would monitor their blood sugar and fasting blood sugar and hemoglobin A1C. Well, these are the things that we monitor, CD4 and viral load. The CD4 should remain above the baseline after the patient starts ARV therapy, and the viral load should hopefully be undetectable, at least to a level of less than 400 copies per milliliter by the time a patient's been on therapy for 6 months. And so that's the goal of our treatment. So what are some of the secondary goals? What are some of the other things that we're going to gain from doing this, from treating people, from making them healthier? Well, as we treat more and more people, there's going to be more uptake of VCT. More people see, and we're seeing that now, because 5 years ago, not very many people were on treatment. Now, more and more and more and more people, each year we're initiating more and more and more people. We start to see, wait a second, these ARVs, they work. I saw people that were lying nearly dead, can't get out of bed, and now they're back to work. They're working, they're running marathons now, and they're doing fine. So these ARVs, they work, and people are seeing that. And so they're saying, well, maybe I'm positive. I'm not feeling well. Maybe it's HIV. I should test myself. So we'll get more and more people to test themselves. And then more people will practice safer sex. If one partner is positive and knows their status, they can do something to prevent their partner who may be negative. If we do these things, if we know our status, if patients know their own status, more and more people test, well, they can do something about it to prevent transmission in discordant couples. They can use condoms. One partner can become on antiretroviral therapy where the risk of transmission is very, very, very low. And then, of course, ultimately reduce mother-to-child transmission. The more women of childbearing age that we get on antiretroviral therapy, the less children will be born with HIV. And as we've seen, and I've given you several examples of several countries where pediatric HIV is almost becoming non-existent. Why? because of good prevention measures in mother-to-child transmission. Several countries now have mother-to-child transmission rates about 1% or less than 1%, which means that pediatric HIV in these countries can go away. And the same is possible here in South Africa as more and more women can get onto antiretroviral therapy, and we can offer them interventions in PMTCT. And we're going to talk more about that specifically in the PMTCT lecture. So what is this? I showed you this in our prevention lecture. But this is exactly what I'm talking about. It's the pathway to prevention. So the more people we test, the more people know their status. The more people know their status, the more people we can treat. And the more people we treat, the more infections we can prevent. Okay? It's the test to treat to prevent pathway. Okay? And I think that's one of the huge, major secondary goals of antiretroviral therapy. The more people we can get healthy and on to treatment, the more people we're going to prevent. Because if someone, as we talked about in the prevention lecture, an HIV-positive person who is on antiretroviral therapy with an undetectable viral load has a very, very, very low chance of passing on the infection, even if they're having sex without condoms. The chance of them passing it on if their virus is undetectable is very, very, very low. Some people say it might be 0. I don't think it's quite 0, but it's very, very low. So then how does this stuff work? What does it actually do? Well, it does one thing. It really has one job, and that's to stop the virus from making more of itself. That's all it does. Antiretroviral therapy has one job, and it stops the virus from making more of itself. And we're going to see this in the pathophysiology lecture later today. But by doing that, by stopping the virus from making more of itself, then the body's able to maintain its immune system and heal the immune system that's already been damaged by the virus. Once we do that, once the immune system is intact and gets stronger, then we prevent opportunistic infections, things that will make you sick that shouldn't make you sick. That's what an opportunistic infection is. It's something that makes a person sick when their immune system is weak. It takes the opportunity to make somebody sick when their immune system is down. And that's what an opportunistic infection is. If we decrease opportunistic infections, we promote normal growth and development, improved quality of life, and prolonged survival. That's the goal of our treatment. But it's not that simple. It's not that simple, because there are side effects, there are problems. You must take the medicine every day in order for it to work. So they need to be monitored at the clinic. And they need to be monitored in several ways. And this is sort of my checklist, something that I go through in my head every time I see a patient who's HIV positive. I, in my head, go through this checklist. I make sure when they come in front of me, I check, how are they doing clinically? Well, that's pretty easy. I ask them, how are you doing? How are you feeling today? And then you examine them. You look for signs and symptoms of disease progression. What is their weight doing? Are they gaining weight? Are they losing weight? Is their weight staying the same? Are they having new opportunistic infections? Are they getting sicker? Or are they fine? Are they back to work? Are they healthy? Are the children back in school? What are they doing? Okay. And then, of course, I make sure that they're up to date on their laboratory tests. Their viral load, as I said, should be undetectable, or at least less than 400 copies, by 6 months. And it should stay that way. If not, we need to do something about it. Their CD4 count should be above the baseline, and hopefully in adults, by about a year on treatment, should be over 200. If it's not, maybe there's something else going on. Maybe there's something we need to do. And then we need to monitor adherence, because, and this is again a whole lecture, but the medicine only works if you take it. The medicine only works if you put it in your mouth twice a day, every day. Otherwise, it doesn't work. Okay? And so we need to monitor patients, their adherence. How well are they doing? And we do that, different people, different clinics have different ways to do it. Common ways, pill counts, medicine calendars, pharmacy refills. All of these are common ways. And again, this is a whole lecture that we're going to talk about ways of measuring adherence during the adherence lecture. And we continue disclosure, and talking about disclosure. And you're saying, wait a second, you're talking about adults. This is the adult guidelines. Why are you talking about disclosure? That's just a pediatric thing. No, it's not. It's not. And this is something that we commonly forget about in adults because we think, oh, they're an adult, they understand everything. It's not true. What I actually find is with a lot of my pediatric patients, they know more about HIV than the adults. I've taken an example in my clinic and had a little girl who's 6 years old go out to the clinic and ask people if they knew the names of their medicines. And the adults would say, no, they don't. And she says, well, I know mine, and she'll tell them. I take Lamivudine, I take Lamivudine, I take Stocrin. And she's 6. And you have 35-year-old adults who can't tell me their medicine. It's pretty embarrassing for them. And then I can have the same children explain how the medicine works. The same children can tell how the medicine works. They say, in a different way than maybe an adult would explain, but they'll say, well, it makes my it makes my virus go to sleep. Right? And so they know. Whereas an adult, they don't really know, well, I know it makes me feel better, but I don't know how it works. And the kids will say, well, it makes my Mesoshaim Zimba get stronger, right? It makes my soldiers of the body get stronger. But yet the adults, they don't know that. So we do, of course, disclosure without calling it that. That's what Module 1 and Module 2 are all about, isn't it? That's exactly what it is. It's teaching adults about HIV. Not everybody knows about it, how it works, how the medicine works, about the side effects of the medicine. And that's what I mean by disclosure to adults. Adults should be aware of the side effects of the medicines they're taking. A lot of them aren't. So if they get one, they might not know what's going on. If they knew about it, could anticipate it, then they'd say, oh, this must be a side effect of my medicine. I need to go to the clinic and maybe change my medicine or do something. But if they don't know what it is, they might not even bring it up to you. So that's what I mean about disclosure. Ongoing education about HIV. Not just Module 1, 2, and 3. It doesn't stop at Module 3. It should be ongoing. As I said, this needs to happen every time you see the patient. Some sort of process of educating them, having them learn about the disease. And then, of course, last but not least, is check for toxicity. This goes hand in hand with monitoring some of the lab tests and clinically, but of course specifically ask about these types of things that you can anticipate because of some of the common toxicities, particularly the amount of adults on Lamivudine. Yes, we've stopped initiating patients on Lamivudine, but many, many, many of our patients continue on it, and they might still develop these side effects of peripheral neuropathy, lactic acidosis, lipodystrophy, anemia. All of these things we need to be monitoring. So what are our weapons? What do we have? What is in our armor? What can we use to fight this virus? This is a list of all of the medicines that we have everywhere in the world. Everywhere in the world right now, this is everything there is for HIV. All the medicines. And this is what we have in South Africa. Actually, there's 2 more that we've recently added. Abacavir and tenofovir are now part of our armamentarium that we have in South Africa, whereas 6 months ago, that wasn't the case. And so it's becoming more. And so one thing I often hear, I say, I hear patients, other doctors, nurses, and say, you know what? You know why HIV is not such a big problem in the UK and in the United States? It's because they have all those new fancy medicines. We don't have, look, we only have these. It's not good enough. Look at all those other ones that we don't have, right? It's not true. It's not true. These same medicines are the same medicines that you use almost all the time as first line, even as second line in the US and the UK. What those new medicines are is usually reserved for people third line, fourth line down the road. I think that will be necessary in South Africa, but not yet. We haven't had treatment long enough to have patients failing first line, second line, and needing a third line. The majority of patients will do simply fine with these. These are what's used as first line in most places in the world. So I don't say, oh, we need those other medicines in order to do something well about HIV. These are perfectly fine. And a lot of the newer medicines, really they're not that stronger, they're not that better. There are only 2 main things about them, is they have less side effects, and most of them can be co-formulated or taken just once a day instead of twice a day. So it's a little bit easier to use and has less side effects, and that's what a lot of the new medicines are reserved for. Okay, so what now about our background? What are the new guidelines for adults? Well, of course, in the guidelines tell us we need to identify patients. How do you know somebody needs treatment? You must identify them. The very same ways you can do it in children. There's symptomatic patients, of course, suspected on clinical status. They come in with signs and symptoms. What are the most common signs and symptoms of an adult coming into the clinic with HIV? Wasting, weight loss, TB. Those are probably 1 and 2. 1 and 2. Weight loss and having TB. Anybody losing weight, any adult losing weight, you need to think about HIV. Anybody with TB, you need to think about HIV. Does it mean everybody with TB has HIV? No. But most patients who are symptomatic and very sick with TB, many of them are HIV positive. And then, of course, remember there's asymptomatic patients. Now, the guidelines have finally moved from VCT to provider-based counseling and testing, but they haven't really yet talked about opt-out testing. And I know Lynn talked a little bit about it during the pediatric talk. But I just want to take a step back and think about what was the focus before. So before it was voluntary counseling and testing, which means what? And remember, we're talking about asymptomatic patients. So think about this. Think about the logic of this. You feel perfectly fine. Not a problem. You're not sick. You're doing fine. But you take a day off of work to go to the clinic to test yourself. And you sit in the queue for how long? Hours. And then you sit there for 4 hours, 5 hours. Finally, it's your turn. You go in and they say, oh, we're sorry. The counselor's on T. And you have to wait. And then finally the counselor comes back and she says, oh, I'm sorry. You know what? We're out of strips. So you'll have to come back tomorrow. We don't have. And so will that person ever come back? No, never. That's voluntary counseling and testing. You have to go to yourself, present yourself to the clinic and say, please test me for HIV. Is that a very good way for people to test the most number of patients? It's not very good. Not very good. So we can use other ways, like provider-based counseling and testing. The patient's already at the clinic. They've come to the clinic for some other reason. People go to the clinic all the time. You stub your toe, you break your leg, you get a cut, you need your immunizations, whatever. You have a flu. People go to the clinic. And when they do, you say, would you like to have an HIV test? Everybody who comes through the door, you should be offering an HIV test. Now, opt-out testing goes a step further. And this is not yet used in South Africa, but it is used many places. Botswana is actually using this, where an opt-out testing is simply testing everybody for HIV and giving them, they can refuse to have the results if they want to. But think about it. When you go to the clinic and you're sick, does the doctor ask you, can I please take your FBC to check if you're anemic? No, they don't. Well, the same is true with opt-out testing. You say, well, it's different. They're looking for a specific disease. Well, does the doctor ask you, can I check you for diabetes? No. Does he say, can I check you for cancer? No. And many forms of cancer have a worse prognosis than HIV. So that's what opt-out testing is. You simply test people, and when you're drawing their blood for something else, drawing their blood for FBC, LFT, you just tell them, listen, we're drawing your blood, we're going to take your FBC, LFT, and we're also going to do an HIV test today. And the patient can say, no, I don't want that HIV test. But unless they say that, they're tested. And this is happening in many places. Private hospitals in South Africa have adopted this. And many places, many countries, even Botswana has done this and has gone with opt-out testing. So is that a very good way of measuring the most number of people for HIV? Yeah, I think that is the best way that you're going to get the most number of people to know their status. So another way that the guidelines tell us, obviously, to identify patients is those who've had a recent exposure, such as in a sexual assault. This is the same theory and same algorithm that we talked about last week when we talked about prevention from a needle stick. The very exact same procedure is followed. If somebody comes in within 72 hours after a sexual assault, they are tested right away. If they're positive, well, then they were positive before the event. And then we do the same thing you would do for any other patient. Clinically stage them, draw their CD4, check them for TB, have them go to the classes. Okay. If the first test is negative, that's when we offer them post-exposure prophylaxis. They get 4 weeks of post-exposure prophylaxis. They're tested again at week 6, 12, and then 1 year. If they then become positive, well then unfortunately they did become positive from that, and we do the same thing we would anyone else. Draw their CD4, clinically stage them, check them for TB, and see whether they qualify for ARVs. If all the follow-up tests at 6, 12 weeks, and 12 months are negative, then they are in fact negative. Okay? We provide post-test counseling, remind them how they are to stay negative, try to teach them healthy lifestyle behaviors. Okay? And then, of course, there's symptomatic patients, which we talked about. I know Lynn talked about this in depth, but the same things that children present with, adults can also present with. TB, weight loss, recurrent infections, fever, chronic diarrhea, all of these things should alert you to possibly HIV. Zoster, thrush in any adult should be thought of HIV until proven otherwise. So if people are having these things, any of these things listed, you can read them for yourself. You really need to offer them an HIV test because the likelihood is quite high. It's not 100%, but it's quite high. So any patient presenting to healthcare should be screened and tested. Of course, that's opt-out testing. It's not part of the South African guidelines, but I think it should be part of your practice, particularly here in KwaZulu-Natal. If you think about it, 40% of pregnant women in KwaZulu-Natal are positive. So 40% of women of childbearing age are positive. That means, you're standing in line at Pick and Pay of 10 people in line, and they say they're all women. 4 of them are likely positive. So 40%, that's extremely, extremely high. Extremely high. So, think about that we screen for diabetes, we screen for high blood pressure, we screen for TB, but the prevalence of all of those things is tiny, tiny, tiny compared to HIV. Whereas in some places it's 40% as a province, but some little pockets it's over 50%. So over half the people actually have it. So how do you assess eligibility? How do you know whether somebody's eligible? Well, the same way for children, you must assess them clinically, immunologically, and socially. So the new guidelines for adults, not a whole lot has changed, but a few specific groups now have increased eligibility to ARVs. So anyone with CD4 less than 200, irrespective of WHO stage, they could be perfectly healthy, they could be running marathons, they could be an Olympic bodybuilder, it doesn't matter. If their CD4 is under 200, they should start ARVs. There's now these 2 new groups that actually have expanded access to antiretroviral therapy. And that's pregnant women and anyone with TB co-infection. So any adult with TB, now if they have a CD4 count less than 350, they qualify for ARVs. And any pregnant woman with a CD4 count less than 350 qualifies and should start antiretroviral therapy. And stage 4, any adult with stage 4 disease should start ARVs. It does not matter what their CD4 is. If their CD4 is 500, yet they have TB meningitis, which is stage 4, they should start ARVs. Okay? And of course, the patient must be willing and ready to take ARVs. As I said, the only way ARVs work is if you swallow them. If patient doesn't want ARVs, if they don't care, they don't want to take it, it doesn't do any good to give them a prescription and to have them leave your clinic with the bottles if they're just going to sit on the shelf. So the patient must be willing and want to take the treatment. And there are certain patients we need to fast track, just like in pediatrics. And so they should start within 2 weeks. Now think of that. 2 weeks of eligibility. A lot of clinics, they have regimen 1 on 1 week, they have regimen 2 on another week, and then maybe 2 or 3 weeks later is regimen 3. Those patients aren't fast-tracked, are they? if they go and batch initiate, which is what a lot of clinics do. So there needs to be a certain method in your clinic to account for these patients that need to be fast-tracked. So pregnant women with a CD4 less than 350. So any pregnant women, as soon as you get their CD4 back and it's less than 350, within 2 weeks, they need to start ARVs. Anybody with a CD4 count less than 100 needs to be fast-tracked. And guess what? Is that very rare? Here? No. In fact, most clinics, the average CD4 count is less than 100, which means you need to start thinking about picking up the pace of initiating patients in all the clinics. Some clinics have done this. They've combined Module 1 and 2 to save patients from coming back to the clinic multiple times. And I agree with that. I think that that method of coming back 3 times is outdated. It's outdated, and we don't need that anymore. If patients are coming to the clinic, they're showing they're reliable, they've already come to the classes, they've come to draw their blood, then just start them as soon as you can, particularly these people. Stage 4 disease, regardless of CD4. And this is another, and I put this, even if the CD4 is not available. Don't sit and wait and wait and wait for a CD4 when you already know that they're available, that they're eligible for ARVs. I see this time and time and time again. A patient has TB meningitis, stage 4. A patient has Kaposi sarcoma, stage 4. A patient has toxoplasmosis, stage 4. And I come into the hospital, I say, why isn't this patient on ARVs? And they say, oh, well, we don't know what the CD4 is. But what stage are they? All of them are stage 4. Do you need the CD4? No. Doesn't matter. Start them on ARVs, and they should start within 2 weeks, according to the new guidelines. And any adult with MDR or XDR TB should start within 2 weeks. Okay. So something needs to be done at the clinic level to try to speed up the process. Sometimes it takes months. I know lots of clinics it takes about 2 months for an average patient to get from tested CD4 back and onto treatment. The new guidelines are telling us in certain select patients that needs to be 2 weeks. And then, of course, there's psychosocial considerations. Now, I call them considerations. I came up with that word because a lot of times they're used as exclusions, and they really, really shouldn't be. But there are certain things you need to address and certain things you need to think about before you initiate somebody on treatment. Are they reliable? So attend 3 or more scheduled visits, and I think this is outdated. And I think this is, a lot of people are not initiating because they don't have the resources, they don't have the money to come to the clinic so often, particularly in that first 1 and 2 months of treatment. I mean, a lot of times if patients are living far away, they come to the clinic and test. They get their CD4 drawn if they're positive and it's a good day. Their CD4 is drawn that day. They come back in a couple weeks and get their CD4 result, right? Say it's now 100. Okay, they draw now their baseline blood. They say come back in 2 weeks. Okay, they come back in 2 weeks, right? And okay, the baseline blood's back. You're ready. Okay, come back Monday for Module 1, Wednesday for Module 2, and Friday for Module 3. Okay, fine, do all that. And now come back the following week for initiations. How many visits is that? Right? That's about 6 or 7 visits to the clinic. 6 or 7 if you're working, 6 or 7 days off of work. If you live far away, 6 or 7 transport visits up and back. If you have a child, 6 or 7 transports for you and the child up and back to the clinic. Costs a lot of money. We lose a lot of patients that way. So, again, if you can combine modules, I often do modules. I have counselors trained in how to do module 1, 2, and 3 in the same day. Okay. Now, is a patient going to remember all that? No. So then they come back and they get re-education. We've created something called Module 4 and Module 5, where after you've been on treatment for a while, you relearn some of these things and refresh them. Again, it's continuing disclosure, even in adults. We should check for active alcohol and drug abuse. We should check for depression. Disclosure to at least one individual or other support group. They should have insight to the disease. They should have access to an ARV center on a regular basis. And this is very difficult for some patients because maybe they're a truck driver and they come and they work in Johannesburg for 3 months and then they work in Durban for 3 months, and they work in Polokwane for 3 months, and so it might be hard for them to access. So you need to come up with a plan for them to answer these. But I call these exclusions, and why do I not exclusions? Why are they not exclusions? Well, I'll give you an example of what happened in a clinic in Swaziland. In Swaziland, there was a clinic that had ARVs, that they started ARVs, and it had one of these things in their guidelines. They said an adult had to disclose to 2 different people before that they started treatment. At the first year this clinic was open, they said they wanted to initiate 1,000 patients. Well, they only initiated about 500. And when they looked back, and they said, well, how could this be? We had how many people? They had about 1,500 patients eligible for ARVs and came through the clinic. So how come only 500 initiated? Well, the vast majority, and the number one reason that adults didn't initiate is because they hadn't disclosed to 2 people. So they said, well, maybe we need to change this guideline. And when they went back to recall a lot of those patients, they had died. So is it better to be dead or to not disclose? Is it better to be dead or still using alcohol? A lot of clinics and a lot of places still use these things as exclusions from ARVs. They say, oh, but he's still drinking alcohol. He can't have ARVs. So what are we saying? He should just die? No, we should address these things. These things, we should have them see the social worker. We should do something about it, but we shouldn't stop somebody from ARV therapy because of these things. There's a question in the back.
Okay, then I'm happy with the challenges as a health worker. You finding that, and you come across with a client or a victim whereby the CD4 count is normal, but it's having the clinical illnesses about 2 or 3, whatever the case may be. Then you are the sister and I've read or I've learned that suppose you enter my ARVs for having clinical illnesses to finish. Whereas my daughter was supposed to sign those ARVs, doesn't understand. Only he knows that the CD4 count must be related to ARV. Whereas we believe that if ever clinical illnesses must be 3, whether your CD4 count therefore is high, but the most important is the clinical illnesses, 2 or 3. What are you going to do as a health worker, as a caregiver, as a counselor? You know the information and you see everything in our challenges in our community, in our clinic. As much as we need.
Right.
But
Yeah, I think it's about education. I know there's lots of people that are stage 4, but because of CD4 count, they're not started on ARVs. And I think a small percentage is because the patient says, I'm not eligible. I think the majority, the patients are sick and they'd want to take them. But it's the doctors, it's the nurses, it's the counselors that say, oh, your CD4 is 201, go home. Your CD, and I've had that, I've seen that. I've actually seen a patient whose CD4 was 201 and they were told to go home. They don't qualify. But maybe it's 250, maybe it's 275, but they're stage 4. Maybe they have PCP pneumonia at a CD4 count of 250. It happens. And they said, well, they don't need ARVs. Let's just treat this. No, it happens, and it's quite common. I think the education needs to start at the top and filter down. Doctors need to learn this. Nurses need to learn this. Counselors need to learn this. And then disseminate it to the patients. It's not just about CD4. And I stress that throughout this course. You're going to hear me over and over again saying that. It's about how is the patient doing. So again, about the psychosocial considerations. If anybody has any of these things, they are important. They are important to the patient's long-term success, and they should be addressed. But most of them can be helped by referral to a social worker. We should work together with the patient, the social worker, the counselor, the nurse, the doctor, to find solutions to the problem, but they should not be an exclusion from ARVs, and the sole reason not to start ARVs. So how do you manage HIV in an adult? This is a flow sheet taken directly from the guidelines. And we're going to sort of go through step by step what to do. So we've already done the first few steps. The person has come to our clinic. We've tested them either through VCT or provider-based patient testing. and counseling, or opt-out testing if you're in a good place, and they're found to be positive. We do prevention counseling. We screen for TB and OIs. Women, we screen for pregnancy, and we offer them our HIV services. Next thing to do is stage them, which we were talking about. You clinically stage them with the WHO system, and we immunologically stage them with the CD4. Now, if they're eligible, they meet if they're not eligible, we're going to talk about that in a few slides. And if they're eligible, they should start ARVs. Okay? So if they're not eligible, then 6 monthly, they should have clinical staging. Most places don't do that. They should have immunologic staging every 6 months, so they should have CD4 done every 6 months. They should discuss HIV prevention, how they are to prevent transmitting the infection to other people. Remember in the prevention lecture I told you that the average HIV positive person passes the infection on to 7 different people. So these people should get counseling on HIV prevention. Because remember, they're not yet on treatment. So they are not part of that group that has a low risk of transmitting. They should be offered isoniazid prophylaxis. This is in the guidelines. I didn't make this up. But nowhere do I know of is doing this properly. Nowhere. Adults who are asymptomatic, who have a high CD4 count, should take 6 months of isoniazid, and that prevents tuberculosis for up to 2 years. So you can actually prevent tuberculosis in many of these patients by offering them isoniazid before they start ARVs, and that can actually even save their life. Many studies have shown this, but it's in the guidelines, and it has been for years. It was actually even in the original guidelines, but nobody's putting it into practice. Females should be offered their pap smear every single year. Again, many clinics are not doing this. Invasive cervical cancer is a very, very common killer of women, and particularly in HIV-positive women. So they should be offered pap smears and contraceptives if they're interested. They should be offered preventative, if they want pregnancy counseling and preventing pregnancy, they should be offered the option that they do have the option to take contraception. We shouldn't push it on everybody who doesn't want it. If you want to have children, fine. But we should avoid unwanted pregnancies. That's one way, and one of the major ways to prevent pediatric HIV is to avoid unwanted pregnancies. So that's what we do for those that don't yet qualify. Okay. So what should we do? And this is a visit checklist, again, taken directly from the guidelines. I scanned this and took it directly from the guidelines. So what should we do at the first visit? Confirm eligibility, complete medical history, do a physical exam, do the laboratory test, screen for TB, check on the need for a pap smear for a woman, which is annually if you're HIV positive, identify and treat opportunistic infections, promote adherence, schedule return visit, start cotrimoxazole or isoniazid as clinically indicated. Again, this is for people who qualify for treatment. Again, isoniazid is not commonly part of most clinics' repertoire when they screen somebody for HIV, ARV treatment eligibility. And then subsequent exams, very similar things. Physical exam, social support, lab support, promote PMT-CT or contraception, information education session. And remember, these should be happening, this is what I talk about again, ongoing disclosure. Every time the patient comes in, they should receive some sort of information and education. And initiate ARTs as necessary. And then every subsequent visit, you follow my checklist that I talked about. How are they doing clinically? How are they doing immunologically? How are they doing virologically? What is their adherence? What is their disclosure? And do they have any toxicity? Those are my list of 6 checklists to go through at every single visit. It doesn't matter if it's 2 weeks, 2 years, 12 years. Every one of those 6 should be ticked off on your list. Okay. So what about those that are eligible? So, very similar to as Lynn said, at 2 weeks we begin working on adherence, explain the side effects, part of disclosure. They should know about the side effects beforehand. It shouldn't be kept a secret. They shouldn't be afraid when they get symptoms, particularly, with Stocrin, if they're feeling weird, they're feeling sleepy, they're feeling lightheaded. They should expect these things, and they can be then counseled about them and learn how to deal with them. Okay. They should have their baseline bloods taken. Then 2 weeks at their next visit. Again, a lot of this is in the guidelines, but a lot of clinics have shortened this to 1 visit, and I completely agree with that. It doesn't necessarily need to be in 2 visits. Again, exclude TB should be part of all routine ARV monitoring. And then clinical assessment, biologic assessment, you look up the labs, make sure that they have an adherence counseling. If they don't qualify, they go back to the clinic and explain why they don't qualify. Maybe they're fine, they're healthy, their CD4 is too high. And reasons for deferment if there are any, and possible solutions. And then the initiation visit. Most of this is a counseling visit when I see the patients because they've already been through the clinic a few times. If they've had TB, it should have been picked up by now. If they've had an OI, it should have been picked up by now. So most of that initiation visit, it's a counseling visit. Explain to them the side effects of the medicine, explain to them about adherence, and explain the drug regimen, how they're supposed to take it, what times they're supposed to take it. All of these are very important. We give medicines for 2 weeks. We call them back in 2 weeks. At that 2-week visit, not much really happens in 2 weeks. So the main thing that we're checking for here, really 2 things. At the 2-week visit, the main things you're checking for are side effects of the medicines and adherence. Are they taking the right dose? Are they taking it at the right times? And are they having side effects? That's the main point of the 2-week visit. The main point. Oftentimes you'll see patients taking Stocrin twice a day at the 2-week visit, when it's a once-a-day medicine. Okay, tenofovir, which is a part of the new regimens we're going to talk about, a lot of patients are taking it twice a day. They say, oh wait, ARVs are twice a day. Well, tenofovir is once a day. So make sure they're taking it right. Sometimes, in children's doses, they need to take 2 pills of some things, 3 of another. You make sure they're taking the right amount. Okay. So what are baseline bloods? This is, again, new part of the guidelines. There's a lot less monitoring of patients on antiretroviral therapy and before antiretroviral therapy, which, again, this is something that some of it I like in the guidelines, because too many people died because they were waiting for LFTs. You see patients with CD4s of 50 coming back to the clinic and coming back and coming back and coming back because their LFTs are lost. And then the blood sample clotted. And then there was a strike. And then something else happened. Right? And they never initiated because they never had their LFTs. Well, the new guidelines are saying you don't really need it. These are the new baseline bloods that you need for starting ARV therapy here in South Africa. You only need a FBC if starting AZT. Does this mean you should never draw an FBC? No. But it's saying you don't need it to start ARVs. I recommend drawing it on most patients because many of our patients are anemic, particularly the children. But should this hold you up from starting ARVs? No. If you're starting AZT, consider it. Otherwise, don't worry about it. Don't worry about it. If they're anemic and their hemoglobin is less than 8 and you're starting AZT, consider starting a different drug or maybe delay and investigate why are they so anemic. ALT is needed only if starting nevirapine. Only if starting nevirapine. How many people start nevirapine? It's not that common. So should LFTs be a reason for you not to start patients anymore? Does this mean you should never draw LFTs anymore? No. It simply means you don't need it to start ARVs. I often still draw baseline LFTs, particularly patients who are on TB treatment too, because they can have abnormalities. But if the results aren't back yet on day of initiation, I don't stop it from letting them start treatment. And that's what these guidelines are telling you. If the ALT is elevated when you draw it, we should screen for hepatitis B and avoid nevirapine. A creatinine, which is part of a UNE, should be taken before if a patient is starting tenofovir. Now this is part of the first line treatment, so patients should have a creatinine before they start. Okay. If the creatinine clearance is less than 50, then you should avoid tenofovir. Okay. So really, with regimen 1 in adults, what's the only test you need before you start? It's a creatinine. It's a creatinine. You don't even need a CD4. Say they have TB meningitis. And so what if you really want to start a patient immediately? What can you do? If you have no blood results, you can use stavudine. You can still use stavudine. It's still a very good drug. If the patient develops side effects, you can switch to tenofovir. I do this very commonly, and patients I do this in are something like pregnant women who present to me very, very late in pregnancy, and I keep not getting their creatinine back. Well, then just start with D4T. You can always switch them if they have side effects. Now we have a little bit more leverage. Before, 6 months ago, we didn't. But now we do. We have a little bit more leverage to switch things and swap things. Okay. Nothing else is required. So really, to start regimen 1, in an adult patient, you need a creatinine. And if you can't get that back, if it keeps getting lost and the patient's sick, well, then just start stavudine. Okay, so this is the new regimens. They've made it very, very confusing by taking the old names of 1A and 1B and 1C and changed what they mean. So it can be quite confusing. But the regular regimen 1A now is Stocrin or nevirapine, tenofovir, and lamivudine. So tenofovir has replaced stavudine, or D4T. Is replaced by tenofovir. You'll see why in a few slides. Regimen 1B is what we're calling the old 1A and 1B, is if they were already on treatment. So nevirapine or Stocrin, D4T, and 3TC. So if patients were already on that regimen, they're doing fine, they have no side effects, they should just continue it. Okay. And 1C is what we're calling is new regimen if patients have kidney disease. So they can take Efavirenz or nevirapine, AZT, and 3TC. Okay, so patients with this will need to have an FBC before they start. Okay. So now the medicines. And I'm going to go through this briefly because I know Lynn spoke about this. So I'm just going to touch about some of the differences between the pediatric medicines and the adult medicines. Stavudine, we all know about. D4T. It used to be the number one medicine, part of regimen 1. But it had a lot of problems. About 40 to 50% of adults would have some sort of side effect from D4T. Whether it was lipodystrophy, lactic acidosis, or peripheral neuropathy. Those were the big 3 side effects of the medicine. Now, in the early days, we used to give a higher dose of D4T. And we saw even more side effects. We decided to drop the dose and see if that helped. It did. It lessened the amount of people that got the side effects, but still a very high number of patients with these side effects. Okay? So, if the patient's already on it and tolerating it, it's still a very good drug. It works very, very well. The main problem with it is toxicity. But if a patient's doing well, not having any side effects, they should continue. If there's any signs, and I've highlighted any signs of toxicity, I would switch to tenofovir if their creatinine clearance is okay. So I used to be pretty hesitant about switching, but now we don't need to be. There's more medicines. There's more things that we can use to switch. So really, if a patient's having peripheral neuropathy, instead of playing with amitriptyline, which doesn't work anyway, just switch them to tenofovir. If they're developing lipodystrophy, and particularly fat atrophy lipodystrophy, we're going to talk about that in the toxicity lecture, but if they're developing lipoatrophy, switching them to tenofovir will help. Okay? And then, of course, the new guidelines say this, and I'm very happy for this, is in patients who are at high risk for toxicity but haven't even developed toxicity yet, we can also switch them to tenofovir from D4T. And now this is in the guidelines. A lot of pharmacists are very hesitant about this, but you can simply bring them a copy of the guidelines and say, hey, it's in there. So who's at risk, high risk of stavudine toxicity? People with high BMIs, people who are overweight or obese, have a much, much higher risk of getting side effects from stavudine. Females, particularly older females, have a much higher risk of getting toxicity from stavudine. And if they're also on TB treatment. So if you have an elderly, obese female on TB treatment, don't wait for the side effects, just switch them to tenofovir. Okay. So this is a picture. There's different types, and again, we're going to talk about this in the toxicity and side effects lecture. But this is fat accumulation lipodystrophy. So you commonly get fat accumulation in the back, in the buffalo hump. Women get enlarged breasts and a big belly. The problem with fat accumulation lipodystrophy is switching regimens doesn't really help. It doesn't help as much as fat atrophy or lipoatrophy lipodystrophy, where switching regimens does help. So switching from somebody who's getting fat and obese from D4T and switching them to tenofovir doesn't help very much. But if they're developing fat atrophy, and you can see there's a few pictures, you can see this in other places, but the face is one of the easiest places to recognize. You can also see it on the arms, the legs, and the buttocks. But I think the easiest place, the place that we often notice it, is on the face. And you see these sunken cheeks. You often see sunken temples with lipoatrophy. That responds much better to changing regimens. So we've changed stavudine or D4T to tenofovir. And why? Because of the improved side effect profile. Very, very low side effects with tenofovir. It's now used for first line and for those who are having side effects from D4T. The main problem it can cause is kidney problems. Patients, and as I tell them, they're not going to feel a thing. They're not going to know they're having kidney problems. They're not going to feel anything. You don't get kidney pain. It's not kidney stones. It's decreased kidney function. And that's why we do need to monitor their creatinine. And that's what doing that does. It monitors how well the kidneys are functioning. You should do it, the guidelines say, at baseline at 3 months, 6 months, 12 months, and then every 12 months after that. Okay. The other main side effect from tenofovir is it can cause osteoporosis, which is weakening and thinning of the bones. This is why we don't use it for pediatrics, at least yet. Because we're not sure about how that's going to affect the children. So in most children, I believe tenofovir is only licensed for children over 18, but there are studies in using it in children over 15 that shows it doesn't really have much adverse effects. It's basically the same as adults. So creatinine clearance, unfortunately, it's a calculation. You don't get a lab test that's creatinine clearance. And it's a bit of a complicated calculation. You actually have to break out a calculator and do some numbers. The good news is most of the time, most labs actually do the calculation for you and do report it on the piece of paper. But if they don't, and I know in the early days, I worked at a few clinics where the doctors didn't start putting people on stavudine for months because they didn't want to bother with doing this calculation. So then I showed them this slide, and more people starting on tenofovir, because you don't need a calculation in most people. Because if their age is less than 50, their weight is over 50 kilograms, and their creatinine is less than 100, then their creatinine clearance is fine. So after I told many doctors that, a lot more people started coming on to tenofovir. You still should do the calculation if it's not done, but if that's the holdup between you and the patient starting tenofovir, keep that in mind. If they're less than 50, it's 50, 50, 100. It's easy to remember because you add 50, 50, and it equals 100. So age less than 50, weight over 50, and creatinine less than 100. It doesn't matter. Their creatinine clearance is fine, and they can start ARVs. 3TC is an excellent drug, and also in the guide, the toxicity of this is very low. It's actually one of the lowest among any of the ARVs. The one side effect is pancreatitis, but it is pretty rare. If the lipase increases over 2.5 times normal, or LFT is over 10 times normal, then you should stop the lamivudine. But this is very, very rare. In 5 years here in Southern Africa, I think I've seen about 2 or 3 cases of this. Not very common. You treat them symptomatically, and this is new in the guidelines, and I've been recommending this before it was in the guidelines, but you'll see where this can be quite helpful. You can actually take 300 milligrams, which is 2 tablets, once a day. So think about what regimen 1 is in adults. It's stavudine. How many times a day do you take that? Once. It's tenofovir, the new medicine. How many times a day do you take that? Once. It's 3 TC. I tell you can take 2 tablets at the same time. How many times a day? You can take it once a day. So now we have a regimen. It's no longer twice a day, is it? Regimen 1 is once a day for adults. They can take 2 tablets once a day. So we usually, because we tell patients to take Stocrin at night because of the side effects. So they should take their tenofovir at the same time. They take 2 lamivudines, and they're done. There's no more morning medicines. They can take their medicines once a day. Now, a lot of patients, I've told this to patients, and they freaked out. And they say, no, lamivudine is twice a day. I know it is. My friend takes it twice. So I say, fine, go ahead and take it twice a day. It's not a problem to take it twice a day, but it's much easier to take once a day. So this is how I initiate most patients. Most patients, I give them this option. You can take your medicines once a day. You just need to take 2 tablets of lamivudine or 3-TC at the same time. Okay, and then there's Stocrin. Now Stocrin, most of my adult patients, when I start them on treatment, and I say, what are your concerns? What are you worried about? This is the one they all worry about. Back before, none of them worried about stavudine, whereas if I'm starting treatment, the one I'm worried about would have been stavudine. But they all say Stocrin. They say, because it makes you crazy, right? Right. Well, no, it doesn't make you crazy. But they've heard some of these things and some of these stories, and they say, oh, we've heard people smoke Stocrin, so it makes you crazy, and all this thing. Well, it does have side effects. It does. But they're actually pretty minimal. It can give you bad dreams, can give you headache, can give you nightmares, make some people sleepy, makes people just not feel right. Some people even reported like seeing things, like hallucinations. But in almost everybody that I've started on stavudine, and I've started hundreds of people on stavudine, they say that some of them, about half of them, say they had side effects. And the other half say they had none. And when I asked those that they said they had side effects, I said, well, how long did it last? And they said it was the 1 dose. And then after that, it was fine. That's the majority of patients. Most people, about half of them do get side effects. But it's for 1 dose, 2 doses. In the research studies, by 2 weeks' time, 95% of the patients didn't have side effects anymore. So yes, the side effects are there. About half the patients can get them, but it's very transient. They just need to bear with it for a few days before they're gone. Okay? This is the medicine that's recommended for TB treatment because it's the less side effects, less drug-drug interactions between this and the TB medicine. So anyone who's on TB treatment should be taking Stocrin. It can cause a rash, which is similar to nevirapine rash, but it's much less likely. Now, officially, on the label in the package, it will tell you that women of childbearing age should not receive Efavirenz unless on a reliable contraception such as Depo, because as we heard in this morning's lecture, there is potentially side effects in the baby. In reality, that's not really bearing out. Several research studies and large analyses, and most of you know patients and people who have taken Stocrin in their first trimester, and the babies are fine. So the biggest risk, really the only risk, is during the first trimester. Outside of that, there's really no risk, because if it's a neural tube defect problem, that's finished by the end of the first trimester. So afterwards, you can't get a side effect that would have already happened already. So outside the first trimester, Stocrin is safe. During the first trimester, potentially unsafe, and I would avoid it if you can. But is it a terrible thing if a woman takes Stocrin during the first trimester? No, I really don't think so. I don't think so. So I have given Stocrin to pregnant women many times outside the first trimester, and their children are fine. Nevirapine to use particularly, now the guidelines will tell you to use nevirapine in all pregnant women. So that's what the guidelines say. So the problems with nevirapine is that there's a lead-in time. For the first 2 weeks, you actually have to take it once a day. So particularly why I don't like this in pregnant women is because most of the pregnant women I see and initiate treatment on is at 35 weeks, 36 weeks, 34 weeks. All right? And by the time we get this lead-in period done, the baby's out. So Stocrin, I think, is a good option, particularly in those women. There's no chance of side effects that late in pregnancy, and you don't have to deal with the lead-in dose. But otherwise, if it is the first trimester, this is what you have to do. So you started once a day for 2 weeks. If there's no side effects, if everything's okay, then you go up at 2 weeks to the full dose twice a day. All right? So this does also require monitoring of liver function tests, ALT at baseline, and then repeatedly. It has the side effects of rash, which can be mild. You saw those pictures, just itchy, bumpy rash, which is fine. They can continue nevirapine. The problem is when it involves a severe rash, the one called Stevens-Johnson syndrome. And that's when it involves the mucous membranes, the lips, the eyes, the genitals. And that is a very, very serious rash. You need to stop all the ARVs. They almost always need hospitalization. And then, of course, it's up to a specialist when to restart and what to restart. Nevirapine can also cause hepatitis, an elevated liver function test, which is why we monitor the liver function tests so frequently on patients. So here's a picture of nevirapine rash. You saw this same picture in the pediatric lecture. This patient, this is just really an itchy, bumpy, annoying rash, and this patient could continue treatment. I'll show you pictures of Stevens-Johnson syndrome in the toxicity lecture later on. Okay. AZT, this is now used as part of now called Regimen 1C. So patients who do already have kidney problems where their creatinine clearance is less than 50. Otherwise, it's reserved for second line. The main problems, the main side effects with this medicine are its bone marrow toxicity. So it can cause anemia, can cause thrombocytopenia, can cause leukopenia. So all low blood counts. We monitor this by doing FBC. Should be done at month 1, 2, 3, and 6. If patients are already anemic, I would avoid AZT. DDI, which is part of second line, actually in adults it's no longer recommended to be used at all. And why is that? I mean, it's still there if you need it, but it's not part of the standard regimens here in South Africa because of the side effects. This actually has even more side effects than Stavudine, and it's harder to take. And I didn't like this as second line because you took somebody who failed first line. What's the number 1, 2, 3, 4, 5, and 6 reason for patients failing first line? Yeah, poor adherence, not taking the treatment well. And now you switch them to a regimen that's harder to take because this has to be taken on an empty stomach. It's either 1 hour before meals or 2 hours after meals. In the old days, the old formulation of Calitra had to be taken with food. So now it was actually harder to take your medicines. You're switching at different times, and this had more side effects. So it wasn't a very nice drug, but it is there. You have to take 2 tablets to make sure there's enough to decrease the acid in the stomach, and that's why you need to take 2 and why you need to take it on empty stomach. In older adolescents and adults, it can be given once a day, so usually we give it first thing in the morning because it's on an empty stomach already, and then tell them to wait 1 hour and then they can eat. Okay. But it does have quite a bit of side effects, pancreatitis, peripheral neuropathy, particularly if used in combination with D4T. They are additive, so the side effects, lactic acidosis, peripheral neuropathy, lipodystrophy, all can become quite severe and quite debilitating in patients taking that combination. And last we have Calitra, or the new formulation of Calitra now called Eluvia, which is a mixture of lopinavir and ritonavir, 2 drugs in 1 tablet. It's used as second line for adults. It's very, very, very robust. I usually don't tell patients this, but you can learn this. It means it actually is a bit more forgiving than some of the other drugs. It's a great second line drug for that reason, is because adherence doesn't quite need to be as high as with the other medicines in your adult patients. Ritonavir is it's a difficult story. The same thing with children. It has a lot of side effects. It can be used to boost in patients with TB. Instead of doubling the dose of Calitra, you can add ritonavir. The problems with ritonavir is most pharmacies don't stock it, most clinics don't have it, and most patients don't like it. It causes a lot of nausea, a lot of vomiting, upset stomach, and it's not. Most patients don't like that. So in patients on Calitra, practically what most people do is double dose of Calitra. So side effects in general, any one of them can cause some mild abdominal pain, nausea, vomiting, dizziness, generally not feeling right, particularly in the first few days on treatment. So what are the new monitoring labs, or what is recommended? These are the new guidelines. I can't say this is the part of the new guidelines that I don't completely agree with, but this is what there is. So it says to draw the CD4 at 6 months, 12 months, and then yearly afterwards. Okay? I'm fine with that, because most patients, after they've been on treatment for a year, their CD4 is fine and stays fine. And really, I don't really care about the CD4 that much. Once it's over 200, once it's over 250, 300, it stays that way in the majority of patients. Viral load, they say to monitor at 6 months, 12 months, and then yearly. That one I have a big problem with. Big problem with. Because particularly in adults are clever, and they like to hide the fact that they're not taking their treatment. And 90% of the time, the way we pick it up is with the viral load. And if a patient's been unadherent, particularly to regimen 1, for 9 months to a year, by the time we pick it up, the horse is out of the barn. It's too late. By the time we address adherence, by the time we do something about it, they're already resistant, and they're going to need second line. Back before, when we were monitoring every 6 months, you could pick it up an adherence problem earlier. So when you do offer an intervention, adherence improves, they go back to taking their medicine properly, they're not yet resistant, and the virus goes back down. It'd be interesting to see with the new guidelines what happens. What I think is going to happen, and what I know is going to happen, is we're going to see a lot more patients failing regimen 1 and needing regimen 2. My understanding is, the reason you can say, how can they do this? Again, everything is a balance, everything in life. It was we get tenofovir, or we check a viral load every year because of cost. And they went with tenofovir because of the side effects. That's my understanding from the head of the HIV Clinician Society. So, that's for CD4 viral load. ALT only if nevirapine rash or symptoms of hepatitis develop. That's the new guideline. Remember before, it was baseline, 1 month, 2 months, 4 months, 6 months, and every 6 months. Now they're saying, never. Baseline, if it's fine, you don't ever need an ALT, unless the patient has symptoms of hepatitis or a nevirapine rash. That's the guidelines. FBC, again, only if on AZT at 1, 2, 3, and 6 months. Still pretty aggressive monitoring with AZT because of the symptoms, or it so frequently has that side effect. Creatinine, if on tenofovir, again, at month 3, 6, and then every year. So baseline 3, 6. So most patients, this is really your only monitoring lab, is a UNE, creatinine. Baseline 3 months, 6 months, and then every year. This is just for your reference. I'm not going to go through it. This is different laboratory values and what grade toxicity they are. You can simply look it up. I don't have this memorized. I have to look it up all the time. So if somebody's having side effects of a drug, particularly laboratory-wise, we grade them. Grade 1 toxicity, grade 2 toxicity, grade 3, grade 4. And the reason we grade them is what you do about it depends on the grade. If it's grade 1 or 2, these are pretty minor toxicities. The patient can remain on therapy. We usually repeat the test. We reassess them in usually 2 to 4 weeks and see what's happening. Grade 3 toxicity is getting a bit more serious. Tests should be repeated within 1 week. If it's still grade 3, we usually stop all ARVs and seek expert medical advice. They may even need to be hospitalized. If it's grade 4, this is very serious and life-threatening. We need to stop ARVs, all of them, immediately. Most of the time they need to be hospitalized and seek expert advice. And then, of course, a specialist should decide when or if to restart ARVs and what to restart. So a few things about some of the side effects. The nevirapine rash, usually the severe one, involves the lips, involves the eyes, involves the genitals. Very, very severe rash. Can be associated with fever. If patients develop this, they need to stop all ART immediately. They should seek a specialist, and they should never again be re-challenged with nevirapine. A little bit about TB and HIV. Again, this is a whole lecture towards the end of the course, but the highlights are timing of TB treatment and ARVs. There's growing bodies of evidence that basically say the sooner you start patients on ARVs, the better they do. For long periods of time, we were always worried about the interactions between TB medicines and ARVs and the development of immune reconstitution syndrome. But what in reality research studies have shown us is that yes, if you start earlier, more patients get immune reconstitution syndrome, but they're perfectly fine. They don't really die from it. They don't get any sicker from it. But when you delay treatment because you're worried about immune reconstitution symptom, they die. So growing bodies of evidence are saying patients with TB and HIV, the sooner we start them together, the better they do. The guidelines say if they're stage 4, it doesn't matter what immunologic criteria they are, they should start within 2 weeks. So what is stage 4? For adults, this is pretty easy. Any extrapulmonary TB is stage 4. So TB abdomen, stage 4. TB meningitis, stage 4. TB of the bones, stage 4. Any of these types of TB, TB pericardial effusion, stage 4. Patients should start ARVs in 2 weeks. Does not matter what their CD4 count is. It does not matter. These patients should start ARVs within 2 weeks. Stage 3. What is stage 3 if you have TB? Pulmonary TB. It's easy to remember because it rhymes. Pulmonary TB is stage 3. All right? Easy to remember, it rhymes. Pulmonary TB, stage 3. So if they only have TB in the lungs, that's their only problem, they're stage 3. Well, then we can use the CD4 to help guide us when they could start treatment. If it's less than 100, remember they should be fast-tracked for multiple reasons. 1 is they're having TB co-infection. 2 is they're having CD4 less than 200. So within 2 weeks, they should start ART. If their CD4 is between 100 to 150, somewhere between 4 and 8 weeks is fine. But as I said, most research is showing the earlier, the sooner you start, the better. In most patients, probably 2 weeks is adequate in really anybody. Really anybody. Okay? And over, if their CD4 is over 150 or higher, within the first 2 months. No longer should we be waiting, and it had been part of the guidelines before. If the CD4 was high, we said wait till the TB treatment is over and then start ARVs. Well, recent research studies from KwaZulu-Natal and South Africa have shown if we do that, patients die about 2/3 the time more than those that take the ARVs within the first 2 months. Okay, so very high mortality if you wait till the end of TB treatment. So no longer is that part of the guidelines. So the sooner the better. Somewhere between 2 weeks and 2 months in the majority of patients is the right answer. So what do we do if they're on a medicine where there's drug-drug interactions? The main one we need to focus on is Kaletra, or lopinavir, ritonavir. Practically what most people do is double the dose of Kaletra, or Eluvia. So Eluvia is, for adults, is 2 tablets twice a day, so we increase that to 4 tablets twice a day. We usually do it gradually because of the side effects. If you just go from 2 to 4, most of them will get severe diarrhea. So we do 2, and then let them take 3 for a few days, 3 twice a day, and then up to 4. You can also add ritonavir, but because of the side effects, limited availability of it, it's not commonly used. But if you did, you would do a 1-to-1 ratio of ritonavir to the Kaletra. Patients should have their LFTs monitored pretty frequently if they're taking TB treatment and double-dose Kaletra together, because there is evidence of higher risk of liver damage when you're doing that. So back to the visit, what do we do? Well, we've actually already gone through this. This is all part of our checklist. 2-week visit mostly is about adherence and toxicity checking. Okay, of course, you do a clinical exam and ask them how they're doing, but mostly it's about adherence and toxicity. At the 4 weeks, okay, how are they doing? We assess them clinically. We assess for toxicity. We assess adherence, ongoing disclosure. Same thing every single visit. Okay. 8 weeks, 12 weeks, really, it's all the same beyond that. You remember my checklist of 6: clinical response, immunologic response, virologic response, adherence, toxicity, and disclosure. Every single visit, those are the 6 things that need to be done. Okay, and there it is. My list of 6. Clinical response, immunologic response, virologic response, absence of toxicity, adherence, and disclosure. This is actually not part of the guidelines. This is part of my guidelines that you should be monitoring every single time you see a patient. A few special considerations. Don't forget patients that are on nevirapine, 2 weeks of the lead-in dose of once a day, then at 2 weeks, twice a day. Many, many pregnant women that have started on nevirapine, I'll see them at 3 months, at 4 months, they're still taking nevirapine once a day. And it's not effective at that dose. So they're just breeding resistance. Okay. Remember, if you order a test, you should look up the results. So FBCs, LFTs, creatinines. If the blood was drawn, you should trace the results and act upon them. Okay. So the criteria for success all go back to my checklist of 6. But patients clinically should have decreased morbidity and mortality. They should have the absence of toxicity. That's how they should be living their lives. Laboratory-wise, the viral load should be undetectable, or at least less than 400 copies per milliliter by 6 months. Their CD4 should increase from baseline in adults. We hope it's over 200 by 1 year. There should be an absence of toxicity, anemia, kidney problems, liver problems, skin rashes, any of those things. They shouldn't be around. We should avoid drug resistance, and we've talked about how to do that. Patients should have good adherence. Socially, they should monitor their partner and children's status. This is something that is very, very rarely done in the clinics, particularly women. We don't ask them, has their partner tested, which is the majority of the time the answer is no. And the other thing that we miss very, very often and commonly and very seriously is we don't ask them about their children. We know if a woman's positive and she has children, there's a chance that those children were exposed. Particularly if those children are 4 and 5 and 6 years old, ARVs and PMTCT wasn't really around that long ago, or not in large numbers. So there's high chance that these children could still be HIV infected. Prevention measures, again, preventing unwanted pregnancy, preventing spread of disease, using condoms. All of these should be addressed. And of course, the patient should be happy. Any questions?